Hello everybody, welcome to the Clinical Reasoning curriculum in the spring session of Mechanisms and Practice. You started discussions of clinical reasoning during your Foundations course overseen by Drs. Gowda and Fink during your preceptor sessions. We are going to continue and expand these discussions in conferences in the M&P course this coming week. What is clinical reasoning? It is a broad concept reflecting many of the cognitive processes that occur in practicing medicine. Clinical reasoning is what physicians do and have always done. On the left, we see a scene from years ago when little was known about the cause of disease. Nevertheless, the physician is deep in thought, thinking about what the diagnosis might be and, if there were any remedy, what that would be. The same scene is played out in modern times in a completely different environment where knowledge and technology have dramatically improved our ability to diagnose and treat. Yet, the process of clinical reasoning manifested by these two young physicians remains the same. All three physicians are deep in thought. What are they thinking about? How do they think about the cases? We can understand the cognitive processes involved in clinical reasoning by examining the clinical encounter. The patient presents with signs and symptoms that prompt us to think about various diagnostic possibilities. Through testing and additional history and physical, we usually settle on a diagnosis and initiate some therapy or intervention. We can see that we engage in diagnostic reasoning in our effort to identify the correct diagnosis, and we engage in clinical decision analysis to identify the best option for therapy or intervention. Both processes rely on reliable and predictive testing and knowing whether a test result is useful. What we've come to realize over the past decade is that there are unconscious cognitive biases that undermine this idealized approach to diagnosis and decision-making. These biases interfere with all three elements of clinical reasoning depicted here: diagnostic reasoning, decision analysis, and test interpretation. The focus of the clinical reasoning curricular thread is thus these four elements: diagnostic reasoning, generating and refining diagnostic hypotheses; clinical decision-making, which is settling on an effective and appropriate plan; accurate interpretation of diagnostic tests; and, sadly, awareness of the influence of cognitive biases. Let us first discuss diagnostic reasoning. Imagine a patient presents with edema. By engaging in hypothesis-based reasoning, what we call the hypothetico-deductive process, through induction we identify three potential causes of edema. Through deduction we hypothesize that certain tests will help resolve which of the three diseases the patient has. If the patient has CHF, the ejection fraction should be low. If the patient has nephrotic syndrome or cirrhosis, the albumin should be low. We find that the ejection fraction is normal and the albumin is low, thus eliminating CHF as a cause of edema. We then reason that if the diagnosis is nephrotic syndrome, there should be protein in the urine. There is, and we settle on nephrotic syndrome. This paradigm is classic hypothetico-deductive reasoning, which involves some deep thinking and a significant cognitive effort. But what if the patient presented to us with all three of these findings, edema and low albumin and proteinuria, at the same time? This is a pattern easily recognizable as nephrotic syndrome. In contrast to hypothetico-deductive approach, pattern recognition is nearly effortless and involves little cognitive effort. That is, of course, if the pattern is recognizable or known to the physician. These examples demonstrate two very different approaches to diagnosis. There is the hypothesis generation, a slow approach known as System 2, and there is pattern recognition, the fast approach known as System 1. The main learning objective in your diagnostic reasoning conference will be on discussing the dual processing approach. Let's next discuss clinical decision analysis. Consider the patient with a cerebral aneurysm. Should the patient undergo aneurysm repair or not? Certainly a complicated topic, to say the least, and in the popular press. There is clearly uncertainty in any such decision because of chance events. The surgery might go well, but there is a chance that the patient will develop a post-op stroke. Also, Some chance outcomes are more likely than others. What is the probability that the patient will develop a stroke? Lastly, patients have their own sense of how chance outcomes would affect their lives. If the stroke is debilitating, maybe the patient would want not to survive the stroke. How can we represent the uncertainty of decision-making, yet attempt to optimize the decision? A useful approach is to construct a decision tree. We start with the decision options, in this case, operate or not. Then we map the possible important chance outcomes. For the non-surgical option, there are clearly at least 2 important chance outcomes: no rupture or rupture. For the surgical intervention, there are at least 2 important chance outcomes: successful repair or stroke. For each of these chance outcomes, there's a probability. For a given size aneurysm, for example, the probability of rupture is well known. And for each of these outcomes, the patient will have a strong opinion as to what the outcomes mean to them in terms of their overall well-being. For example, choosing no surgery and having no rupture might be considered the perfect outcome to one patient, but not optimal to another who would worry the whole time about potential rupture. A stroke might be acceptable to some patients because at least they tried, and completely unacceptable to others. As we will see in conference, we can assign a value, a numeric value to the outcome, and by knowing the probabilities, actually calculate which decision, surgery or not, is favored. The decision analysis approach thus provides a framework to cope with uncertainty. It provides a checklist to identify decision options, the important downstream chance events outcomes, and their estimated probabilities. These actions require consulting the literature to inform the analysis, which reinforces evidence-based practice. Lastly, in considering the impact of each outcome, the student focuses on the patient assessment, which reinforces shared decision-making. The goal of the Clinical Decision Analysis Conference will be to learn how to construct a decision tree and identify the best option. Let's move on to the next topic, testing. An essential skill of sound clinical reasoning is the ability to assess the utility of a test. Testing is used in screening and confirming or ruling out a diagnosis. Some tests are better than others. Consider the use of mammography to detect breast cancer. Over the past few years, breast cancer screening using mammography has become quite controversial and sparked a national debate. The essential question is mammography a useful screening test? In order to answer that, we need to know the positive predictive value of the test. What is the probability that the patient has breast cancer given a positive test? And we'd also like to know what the probability is that the patient does not have breast cancer given a negative test, the negative predictive value. These probabilities can be calculated by knowing 3 facts: the pretest probability of breast cancer, usually the prevalence of the disease, and the sensitivity and specificity of mammography. The focus of the conference on testing will be to assess the utility of a test. You will make the calculations of positive and negative predictive value so you can decide whether mammography is a useful screening test for breast cancer. Our last topic is cognitive biases. As mentioned, unconscious biases influence our clinical reasoning, often sending us in the wrong direction. Jerry Grubman, a PNS grad from the 70s, went public on national news after writing a book, How Doctors Think, stating that biases are often responsible for misdiagnosis. In fact, biases can influence all aspects of clinical reasoning process, causing misdiagnosis or misinterpretation of lab tests, or choosing the poorer intervention. 2 examples reinforce this point. Diagnostic reasoning can be impaired by cognitive bias or error called diagnosis momentum, where the patient's initial diagnosis remains unquestioned by subsequent caregivers. Once diagnostic labels are attached to patients, they tend to become stickier and stickier. Consider the patient admitted from the emergency room with a diagnosis. The admitting physicians taking care of the patient in the hospital may not question this diagnosis further and start treatment immediately. The admitting diagnosis might be incorrect and may well have been identified had the admitting physicians considered alternative explanations. Consider decision analysis and the decision tree. The usefulness of the analysis depends upon accurate probabilities. In the case where the physician over or underestimates the probability, so-called base rate neglect, the best decision identified through the analysis may not actually be the best decision. The goal of the Cognitive Bias Conference will be to recognize the common biases that undermine clinical reasoning. So our clinical reasoning sessions will focus on 4 of the basic skills of clinical reasoning. In diagnostic reasoning, you'll discuss dual processing. In clinical analysis, you will create a decision tree and identify the best option. In test interpretation, you will calculate the positive predictive value of a test. And in cognitive biases, you'll discuss various biases that undermine effective clinical reasoning. I'd like to finish up this introduction by discussing your responsibilities and milestones. During the spring M&P sessions, by participating in the conference discussions and class activities, you will learn some of the skills that underlie sound clinical reasoning. The skill set will be reinforced during the clerkships when you'll have a chance to complete short assignments based on the clinical reasoning curricular thread. Lastly, the skill set will be refined in the M&P fall sessions when you have the opportunity to discuss your clerkship experiences with clinical reasoning. A final word about your conference leaders. Diagnostic Reasoning and Cognitive Biases will be overseen by Kathy Nickerson, Andrew Mutnick, and Mary Jo Fink. And Clinical Decision Analysis and Test Interpretation will be overseen by Josh Wiley, Ben Lebwall, and me. Welcome to the Clinical Reasoning curricular thread. We are looking forward to seeing you all at the M&P spring session. Thank you.